This is the first episode of the AMI Health Podcast. We have our two stars here, Dr. Aya Odolate and Dr. Kelsey Williams. And today we're going to focus on, I think, breast imaging and breast surgery. First, I'm going to talk to Dr. Odolate and find out why breast imaging.
Well, that's a great question. During residency, you have an opportunity to kind of further subspecialize in whatever field of radiology there is. And at the time, early on in my residency, I really loved abdominal imaging. Like I was going to be an abdominal imager, so that would be focusing on the abdomen and pelvis, MR, CT, and interventional things. And then we don't get into mammography rotations until your second, third, and fourth year of radiology residency. It's a 4-year residency. But I found the environment in the breast world to be fantastic. They have a wonderful working relationship with the technologists. I mean, basically, it's kind of one-to-one. Without the technologists in mammography, we're basically nothing. So it's just a wonderful environment, and I love helping women. I love speaking to women. I speak to women every single day, which is kind of a different thing than what people generally think radiologists are, that just sit in the dark and kind of crave cave creatures. But I interact with patients on the daily, either through biopsies or with speaking with them about having to perform a biopsy. And I just find it very fulfilling.
That's fantastic. And I do remember you trained in the East Coast. Where did you train?
Brigham and Women's Hospital.
Okay, and did that have a huge breast program?
Oh, absolutely. Yes.
Perfect.
Yes.
Perfect. Dr. Williams,
Yeah.
Our foremost well-known breast surgeon. Why breast surgery?
Yeah, so similarly in training, you rotate through a lot of different subspecialties, and I loved surgery kind of from the get-go, just like the environment of being in the operating room. And then again, similarly loved helping women, and so just love the patient population. It's very multidisciplinary, so we work closely with radiology, medical oncology, radiation oncology, and so I love that team aspect of it. And then just being able to help walk women through a really difficult time in their life, hopefully to, just to help them get through it. And so it's, again, a really fulfilling.
And you grew up in the South?
Yeah, you could call it that, Virginia.
Okay, Virginia.
So the southern part of Virginia, but yeah, East Coast.
And you trained out where?
Yep, in Virginia. So Roanoke, Virginia is where I did my surgical residency, and then Philadelphia for breast fellowship.
Well, we're thankful both of you are here, but you are from Nebraska, though, kind of. Well,
with an asterisk. Yes. My mother was in the Air Force. She was at Offutt, so I was here for high school and college.
Okay, that's awesome. Well, I mean, this is when AMI decided to go on this journey of the breast program. I think it was so important to get these two because this town was always good with healthcare around women's health, but like I think we just upped the ante when we did that. So I want to just kind of talk about why we do this show. The show is going to be about getting to know your doctor first and foremost, and then getting to know why they chose to be passionate about the things that they do. So today's a very important topic, is breast cancer and breast health is very personal to all of us in some way or shape or form. So I want to know when people have misconceptions about breast cancer. I'm going to start with you first. What is the biggest misconception people think about?
The biggest misconception that I hear directly from patients is that I don't have a family history of breast cancer, therefore I'm not at risk. And in fact, the exact opposite is true. Most women that develop breast cancer have no family history of breast cancer. Only about 10 to 15% of women have a genetic association or family history of breast cancer. So in fact, when you don't have a history, it means nothing. And that's a huge misconception to patients, because then they delay doing screening. They delay care sometimes because they have this idea that I'm okay. I don't have any family history of it. But
wow.
It's the opposite.
It's the opposite. And have you been seeing that in your
career? Absolutely. Yeah. I think that paired with I'm not having any symptoms in my breast. I don't feel a lump. Everything feels fine. And again, we would say the goal of mammography, right, is to find things before they're palpable, before we can feel them. So yeah, I totally agree.
How many of the women that come to your clinic you just find randomly, what they were checking themselves, or versus how many of them come from a mammography screening because of just the screening protocol we have out
right
there?
I'd say the majority from screening. Again, a lot of it has to do with, are they getting their mammograms regularly or not, but I'd say the majority of women are from a screening mammogram.
And do you find that, and this may be a question for both of you, but
Yeah.
do you find that the screening protocols that we've put in place by, I think, the U.S. Health systems have put in place are good, or they're lacking, or do you think they should be better? Maybe that question's better for you. Yeah.
Well,
So the general guidelines is women at the age of 40, which are average risk, should
Uh,
begin screening mammography. And even you can have a kind of baseline examination up to 5 years before that time.
mhm.
And that's a different subset of patients that are increased risk. So they have a different kind of set of recommendations. But in general, women by the age of 40 should have a baseline screening mammogram. I feel like in the United States, we do a fairly good job. I know a lot of countries in Europe, they start their screening programs at the age of 50,
okay.
and some
Mhm.
of that is financial causes.
Hmm.
But in order to save the most lives, beginning screening mammography at the age of 40 has been shown to save the most women's lives.
And have you seen that translates to you seeing more patients in clinic, or have you been able to just, it didn't change much for you, or is it?
Yeah, I mean, again, there's been kind of over the years changes even in the US. So there's different task forces and the American College of Surgeons versus, yeah, other things. But I think pretty much now 40 is agreed upon to start. There's differing, I think, questions on annual versus biannual, but most it's annual starting at 40, which I think is great and agree with. I certainly um, yeah, we're seeing younger and younger women
Oh gosh.
diagnosed,
Okay.
and so again, I think the average age is still kind of in your 60s, above 50, but certainly that patient population of younger women is increasing over time, younger diagnoses. So,
So
yeah.
if I were to say, give an example
Hmm.
of a typical, I don't want to call it typical breast
Yeah.
cancer patient, but like, you see how what's the process? How do they're at home.
Hmm.
So let's take a person that goes for a screening. Then what happens at our clinic?
Yeah.
What happens? How do they come here? What do they do? Like, do they fill out a form and they send in a postcard? Or what actually happens to get them to us?
Yeah, I mean, I can maybe speak on the
Yeah.
imaging side, just showing
Yes.
up for their screening
Okay.
mammogram,
Yes.
and
Yes.
Let's
then
start with
from
that.
So
Yeah.
let's
there.
start
Yeah.
there.
Yeah.
So actually, the federal government has mandated that any woman 40 and above can get a screening mammogram without a physician's order. And that's important because
Mm,
everything else in radiology, you need a physician's order in order for that radiological examination to be performed. But this is the one area that's been carved out that any woman off the street can walk in. They don't have to have a primary care doctor. They don't have to be associated with anybody. They can come in and request a screening mammogram, and we will perform it. So that's where it starts. So a woman
okay.
comes in for a screening mammogram. If we find something that looks suspicious or unusual, we would call her back for usually a diagnostic mammogram and or an ultrasound. If we were still to find that there was something unusual, then usually a biopsy would be recommended at that time. We would discuss those recommendations with the patient at the time that she's
Hmm.
here.
Hmm.
During those exams, we would set her up for a biopsy, and then the biopsy would be performed. If that biopsy was positive for cancer,
Hmm.
then usually a recommendation to our breast surgeon, such as Dr. Williams, would be performed, and then she would kind of take it from there.
Okay. So
Yep.
as soon as they diagnose something on theirs, and then they come to you, what happens then?
Correct. Yeah. And so our goal is to get women in quickly to
Hmm.
kind of ease some of that anxiety. And again, we see patients in our clinic cancer, but also sometimes the biopsy shows things that are atypical, but not cancer that still could need surgical intervention. And so we see all of those patients. And so um, they're referred to us, we bring them in, and it's really just an initial consultation to go over. I like to review kind of from start to and the imaging starting back with their screening mammogram so they can actually see the
Hmm.
images.
Hmm.
Sometimes they do see them when they're on ultrasound, it's easy for the patient to see, but sometimes they haven't actually been able to look at their mammogram or imaging. So we kind of review all of that and obviously go over the pathology and what would be recommended, their options. A lot of these discussions are very individualized
Okay.
and patient preference. And so there's certain recommendations that we may discuss, but at the end of the day, it's what's the patient comfortable with. So,
So when
yeah.
once they get that news, they have cancer.
Hmm.
Then they come. I guess afterwards they come see you.
Yeah.
We have a lot of referring colleagues. We have a lot of colleagues in this town that
Yeah.
they're involved in care. So what else? Which other doctors get involved in the care? What else happens in their journey here?
Yeah. So if we're the first step, which a lot of times we are, we work very closely with medical and radiation oncology in town. And I have a nurse navigator who's wonderful that kind of helps facilitate consultations with those providers if they're needed. And most of the time they are. Again, it's a team sport, and so
Mhm.
it takes input not just from me, but a lot of what I do can impact other providers and what they're going to recommend medical and radiation oncology. So
So
yeah,
then after that, in this whole process, at least with AMI, we've been good about trying to make it a one-stop shop.
right.
Is have you seen in the places, other places you guys have been, that it's been different than a one-stop shop?
Yeah, I mean, AMI definitely is unique because it's all kind of under one roof,
Hmm.
at least the radiology and surgery. It's really nice to be able to just walk up and review imaging because it's so crucial to what I do with the radiologists. And again, I just think getting people through timely, we surgery center here, we can do the
Hmm.
majority
Hmm.
of these surgeries can be done on an outpatient basis, which is great. So a lot of women can just kind of walk through the whole process, and then again, referring out to medical and radiation oncology, of course. But yeah, I think it is a unique setup for sure.
And Dr. Lada, you mentioned that my family doesn't have a history of breast cancer, so I'm safe type of environment. Why is that not true? Like, what's is it something genetic, or how breast cancer? Why do you get it?
Mhm.
Basically, if you have two X chromosomes.
Okay. Okay.
Yes,
Yeah.
yes.
Okay.
So that and age. So in fact, the incidence of breast cancer increases as women get older.
Okay.
And some
Mhm.
people seem to think that, oh, I've reached the age of 65, I'm good. In fact, that's when you're highest risk. I mean, up to 80s or so. And that's just how it is.
Okay.
The
Okay.
Mhm.
good news is that most breast cancers are found early stages. And that's when women have the best outcome of beating it.
Got it.
So yeah,
Okay. So it really, you have to, if you catch it early, that's the best option.
always.
Obviously, Dr. Williams, you see
Mhm.
patients, you catch them early, and
Mhm.
you uh, has the technology or the the treatment modalities made things better in the years
Mm.
you've been practicing?
Yeah, I mean, things have changed significantly just in the surgical management of breast cancer. Again, it's all about individualizing care, but ideally doing what's necessary to save lives and treat women, but not overtreat. And
Hmm.
so that's a big topic in breast surgery, is what we call de-escalation of care,
Hmm.
and where yeah. So I think again, definitely catching things early helps me to be able to potentially do less with less long-term impact on patients' lives. Lumpectomy, breast conservation, minimizing how many lymph nodes we have to take out,
Okay.
which the more we take out can lead to long-term side effects like lymphedema of the arm, which can be a lifelong issue. So yeah, finding it early definitely.
Dr. Odolate, what about you? What is the most challenging thing you've seen?
Um, Younger patients,
Yeah.
actually.
Yeah.
It's very sad.
Mhm.
Me personally, I'm seeing younger and younger and younger patients with
Mhm.
breast cancer. We're finding it on screening mammograms, or perhaps they're coming in with a palpable lump, and you would otherwise think it was probably the most common mass in a young woman would be a fibroadenoma. Those
Hmm.
are benign,
Mhm.
and then you do a biopsy and you find out that that's exactly not what it is. It's just those are challenging because they require more diligent care because we're trying to save more of their life. Not that they're worth more than other people, but usually, cancers that arise in younger women tend to be more aggressive, so
Mhm.
their treatment paths tend to be more complicated, more difficult, and challenging.
Well, and I've heard that the new term nowadays is breast density. They talk about why. I mean, I'm not a mammographer, but I try to pretend to be one occasionally. But so why the term breast density? Why is that such a hot topic now?
Great question. So, breast density is something that we can identify on the mammogram. And essentially, what it is the amount of fibroglandular tissue versus fat that you have in your breast.
Hmm.
There tends to be a kind of a natural curve distribution of women with, fatty breasts and dense breasts, and it's about 50-50. But the reason why that's important is because as there's more fibroglandular tissue in your breast relative to fat, it makes it much more challenging for me to identify cancer, either calcifications, which could be the very early form of breast cancer that we can detect, or masses, because masses can hide in that dense breast tissue. So
Hmm.
mammography, although it's very good, it's not as good when you have very, very dense breast tissue. That's why supplemental screening is recommended. So that can be done by ultrasound, which doesn't care about the density of your breast tissue. We can see masses well, then all kinds of dense breast tissue with ultrasound and or MRI, which is the most sensitive type of screening test that we can perform. There's some reasons why a patient may gravitate more towards MRI screening versus ultrasound screening. Perhaps if she's in a higher risk, not if she's in a higher risk, she definitely should be getting MRI screening. That's the recommendations. But if she's in that intermediate category and her breast tissue is extremely dense, perhaps she should lean more towards MRI than ultrasound.
Hmm.
Um, but that's the reason. So mammography is just not as effective. It's good. We can't discount it. We cannot dismiss it. We still have to use it,
Mhm.
but it's just not as good in patients with dense breast tissue versus fatty tissue.
So some of the misconceptions if you're a general patient out in the public, we get so much radiation. Is that
Mm,
true?
No,
mm.
Okay,
absolutely
that's
not.
important.
Yes,
Yeah.
yes. You get more background radiation just by living here in Nebraska with radon.
Okay, okay,
I have that radon
okay,
little
gotcha,
device in my basement, so
gotcha.
that's not an issue. It's
So
not
that
an
means
issue.
get your screening. It's
That's
Yes,
not
right.
that much.
yes.
So really, it's not that much radiation, and it could really save your life if you get it early.
Absolutely. Pregnancy, and there's no need to, there is never a reason why we say a woman cannot get a mammogram. None. Even if you're pregnant, you can still
Mhm,
have a mammogram.
Okay. And does
mhm.
the density of the breast affect how you change your surgery, or does that not affect you much?
Not really. Certainly breast density can make things a little more challenging in the operating room for different reasons, but as far as how we approach it, it's generally the same. So yeah, I think it's most important on the imaging side of things. Certainly, breast density is a slight risk factor. It's small, but there's a lot of risk factors for even developing breast cancer. But breast density is one of them. It's not anything you can really control necessarily, but it does slightly increase your risk for breast cancer. So just something for women to be aware of. And yeah.
When women, sisters,
Hmm.
cousins, aunts, uncles, they find out, hey, I got to go see a breast surgeon.
Hmm.
They're probably in their mind they're thinking, what's the surgery going to be like? What's
Hmm.
the so describe kind of like the process of that. Like you know, how do they recover? What happens
Yeah,
after that?
a lot of it depends what we're doing,
Okay, sure,
obviously.
of course.
But I would say in general, women do extraordinarily well with breast surgery. Um, Here at AMI, we have it set up pretty well with, anesthesia is important, but we do a lot of pectoral blocks for pain control afterwards. And so I'd say, especially for lumpectomies, the majority of our patients take very minimal pain meds after. Um, Mostly Tylenol, Motrin, some, lifting restrictions afterwards. But by the time they come back for their 1 week screening, 1 week follow up, most women are feeling
So
pretty
is it
good.
usually
So
mostly a 1 day surgery?
yeah, usually outpatient. You come
Okay.
in, if we're doing a lumpectomy or like that. The surgery takes 30 to 40 minutes and usually done. Certainly, things like mastectomies,
Mm-hmm.
reconstruction can add more time and can sometimes take two different surgeries up to that. But yep,
Okay.
even with that, women tend to do well.
So let's pivot for a second. We're going to talk about a little bit about Nebraska. Why Nebraska's so great.
Yep.
Listen. I'm the biggest cheerleader in Nebraska, known man. For football, basketball, you want me to put it, but this way, I want to talk about Nebraska health. What have
Yes.
you noticed about how we, as physicians, practice in Nebraska that
Yes.
makes it the place you want to work?
So I came from Southern California. I did
Okay.
my training in Boston, and
Okay.
then after training, we moved to Southern California for family reasons, and then we moved here. What I noticed is specifically here in Lincoln and perhaps Omaha, though I don't really spend that much time in
Yeah.
Omaha. It's a great city. The population here, in terms of the patients and the physicians, are fantastic. Insurance generally is very good here in
Uh-huh.
Nebraska.
Hmm.
Most patients have very good insurance, which is important because the financial aspect of healthcare is a
Mhm.
significant portion of it. But the patients are just savvy with their healthcare. There's a fantastic health practitioner environment here.
Mhm.
It's the best I've ever seen in any place, whether it be East Coast or West Coast. It's just fantastic
I
here.
did know that. How about you? What do you think?
Yeah, I would echo that. The same thing. Just patient population in general. People are very kind, very appreciative, and just the collegiality of colleagues and working together with other providers. Significantly different than some other places that I've been.
And
So.
I can echo this in the world I live in too. But when I moved to the Midwest, I didn't know
Mm,
what to expect. I came from the East Coast too, and I'm I'm like going, oh, this is going to be a small town. Oh gosh, are you going to be
Yeah.
able to get to see a doctor? You find that we
Mm.
have great access to
Oh
all
yeah,
our physicians, right?
for sure. Yeah. I mean, yeah, I think there's top care here in Lincoln for sure. So yeah.
And especially at AMI. Just want to put that out there. I want to talk about a little bit about what's it's a positive and a negative. Social media
Mm,
and what you hear out there. So I'm going to ask you first.
yeah.
Have you felt that social media has been a help or a hindrance to you?
Um, Again, I think a little both. I think it brings awareness to people where again maybe they didn't have screening on their radar, and then they see someone diagnosed with breast cancer, and oh man, I should go in for my imaging. I think the downsides are is there's a lot of misinformation out
Hmm.
there, and so dealing with that and making sure women understand the facts surrounding their diagnosis, and that every patient's different. So one patient's journey, like there's so many different types of breast cancer, treatment varies with that, and so some people come in their mind like, I know, I saw this and this is what I need to do, and it's like, no, let's take a step back and kind of
And
yeah.
we at AMI practice evidence-based medicine. You
Right.
want to talk
Yeah.
about what is evidence-based medicine?
Yeah. I mean, evidence based is, it's based on the facts. It's based on studies that have been done in medicine that, have been outcomes looked over many years to, confirm validity. And so it's not just, well, my neighbor
Right,
had
exactly.
this and
That's what.
did that. And so that's what I should do. So, yeah.
So and that I think that has been one of the hardest things to deal with since the last 5 to 6 years is just misinformation
Hmm.
and people trying to do new things that they heard their cousins, aunts, father's friend
Right.
told them that will help. And breast cancer is serious enough that we don't want to deviate too much from evidence
Right.
based. Would you agree with that?
Absolutely,
Yeah.
yes, yes.
And any misconceptions you're seeing in social media that bother you?
Well, I do tend to get on the TikToks, so I have seen some platforms say that they've been diagnosed with breast cancer. We don't know what the type is,
Right.
what stage it is, stage
Hmm.
0, stage 4. But then saying that I'm going to do these naturopathic type of treatments that haven't been proven, haven't been studied at all, and then it's just a shame because then I read the comments, and unfortunately, a lot of people comment like, "Oh yes, that sounds like the plan," and or I'm going to eat, natural foods and things like that. And my point is, breast cancer has been around for as long as humans have been
Hmm.
around. Before there was all the chemicals that we're exposed to in our environment, in our
Yeah.
food,
Oh yeah.
and so eating well or changing your diet is really not going to be what's going to get you to a cure.
Yeah.
And so that's what I kind of feel sad about.
Right, and I
Hmm.
think I think have you found and this is a good question. Has the incidence of breast cancer has has been steadily going up or has it been going down?
The incidence has been going up.
Okay, gotcha.
So it's a
Hmm.
little bit of a difficult
Okay,
puzzle
yes, sure.
to take apart because with more screening, we find earlier cancers.
Hmm.
We find cancers that may have never turned into anything that would have been significant for the patient. About 50% or so of DCIS, which is the early stage of breast cancer, sometimes we can identify with mammography. Half the time they'll just remain DCIS and they
Hmm.
won't advance to invasive cancer. And invasive cancer has the ability to go to different parts of the breast,
Hmm.
and so that's the type of cancer that we need to treat. But because we don't know which half of DCIS is going to turn into invasive cancer, we kind of have to treat all of them with
Hmm.
some caveats. And so so that that's the important part.
Okay, and then do you feel that your therapies, or I mean, I know you're a breast surgeon, but what
Hmm.
do you think about what's out there right now for? Is there something that you think is cool that's coming in the pipeline, or any new techniques, new therapies that will help
Man.
treat breast cancer?
Yeah. Well, in the surgery world, I feel like, we've developed with nipple sparing mastectomy, or I've started doing some nerve grafting with one of the local plastic
Oh, cool.
surgeons, which is
Oh, yeah.
cool. Traditionally, most women, after they have a mastectomy, even a nipple sparing, which is where we save all of the skin, the nipple areola, it's a cosmetic procedure, but sensation to the nipple or the skin is usually lost. And so we're trying to preserve some of the nerves that maybe supply that and work with plastic surgery to do a nerve graft up to the nipple where women can potentially get some sensation back.
Hmm.
So that's kind of cool that what we're doing here. In general, it's ever changing, from the oncology standpoint. There's a lot of new developments as far as immunotherapies and things like that that um, are really having some really good outcomes. Some women get that type of treatment before I ever take them to surgery, and the percentage of women who have what we call a pathologic complete response, where that chemo or immunotherapy really shrunk away all of their cancer, has kind of skyrocketed recently. Recently, with some of the more aggressive subtypes like triple negative breast cancer. So I think those are exciting things where um, women's lives are being saved with cancers that traditionally were really aggressive and worse
Is this
outcomes. Yeah.
something you discuss in a multidisciplinary fashion here?
Yeah, so we definitely do. Like I say, it's a team sport. And
Hmm.
so, whenever I see a patient, they're pretty quickly seeing medical oncology, and we're having those discussions of, do they need any therapy before I go to surgery, or is it surgery first? So definitely.
I participate in tumor board also with
Yeah.
you guys in a different way, but do you feel that that is something that has been very helpful for our patient population here?
Yeah,
Okay.
absolutely.
Do you
Yes,
agree?
Absolutely.
I
Yeah.
agree. I agree.
Hmm.
Before coming to Nebraska, I was at a small little community
Yeah.
hospital
Mhm.
in California. And just to plug our fantastic surgical oncologists here, the fellowship trained breast oncologists are just fantastic.
Okay,
Hmm.
fantastic.
So the surgical outcomes that I've seen here versus where I came from is just hands down, just no comparison
That's
in
awesome.
terms of technique that Dr. Williams does. Sometimes periolar incision. Sometimes it's even difficult to exactly identify where the surgery was performed because she's got skilled hands. And then I also just wanted to also plug our radiation oncology folks.
Yeah.
So
Hmm.
their different tools and techniques are all also significant. Has a significant improvement in treatment outcomes for
Do we have
patients.
access to great
Absolutely.
radiation oncology here? Yeah,
Absolutely,
that's
yes,
I've heard
Yeah.
the same.
yes.
I think for a small town like Lincoln, we have access to some of the really
Yeah.
technologically advanced treatments that
Oh, yeah.
you wouldn't find in a
Yes.
lot of
I
places.
get patients a lot of times that, talk about getting second opinions, at big med centers. And I usually say, you do what you want,
You're right.
but I mean, you've got top of the line here in
Yes.
Lincoln. So, yeah.
And I think that kind of is a message. Well, actually, I'll
Yeah.
leave the message to you. So, if there was one take-home message that you'd like to say to our audience, or whether it's physicians or our patients, there may be patients listening to this. What would you say is the take-home message from you know this breast health type of environment?
Yeah. I mean, I think for women, it's really just know your body, be aware of kind of what your baseline is for your breast tissue. And if you ever notice a change or have anything you're worried about, obviously let your physician know. And then again, even outside of that, just the importance of getting screening. And again, it really does save lives. So,
Yeah.
And I meant to ask you this in terms of technological, because we at AMI try to be advanced, in technology too. It's in our name. So, what advanced technologies or screenings or imaging type of stuff is coming in the future for
mm,
breast care?
That's a great question. So, the biggest improvement that has happened in the past 10, 15, 20 years has been tomosynthesis
Hmm.
imaging.
yeah.
So, if you think of an x ray as you get a two-dimensional image of a portion of the body that you're x raying, such as a chest x ray or your belly. And if you know what a CT is, the CT kind of gives you individual slices, like bread slices through the body. That's the difference between 2D, regular old school
Hmm.
analog or even digital mammography versus tomosynthesis imaging. So we're able to peer inside the breast tissue at a slice by slice level, and that has really led to a significant improvement in detection of breast
Hmm.
cancer,
Hmm.
and also a significant decrease in identifying things that turn out not to be breast cancer.
Hmm.
So that sometimes is a little bit scary to patients when they come in for a mammogram and we see something and we're not sure, and then they're called back for that diagnostic
Yeah.
mammogram. Sometimes patients don't come back because they think, oh no, that's the end of the world. And in fact, most of the time it's not. Most of the time that repeat diagnostic mammogram, and it shows that there's nothing there. But that tomosynthesis imaging has decreased those kind of false positive
Okay.
exams, and that's
Okay.
been a significant improvement. MRI has been a game changer. The next thing down the line actually is probably going to be contrast enhanced mammography.
Oh wow.
So essentially, what that means is similar to CT examination, although slightly different. We give contrast to better see the different parts of the body
Mhm.
with a CT exam, say for instance of your belly. We do the same thing with mammography. We don't currently offer those services here, but I think in the near future we will be. But essentially, what happens is, generally speaking, and of course we're speaking in generalities. Generally speaking, breast cancers are aggressive and they multiply too often, and that's what makes them a cancer. And in order to do that, they have to have the blood supply to feed that activity.
Mhm.
And so, what we see is increased blood flow to cancers relative to the normal blood flow of breast tissue. So, that's the mechanism of contrast enhanced mammography. We can see those areas of increased blood flow that may suggest that there might be cancer there, or maybe early changes of atypia, and then we can biopsy that.
Oh, that's
So
amazing.
that's going to be coming down the
That's
pike.
from the
Hmm.
diagnostics. That's amazing.
Yes.
Is there going to be a cure for breast cancer? Or let me put it this way: you hear about gene therapy,
Yeah.
fixing. Is there anything you're
I mean,
hearing?
I joke all the time I'll be out of a job soon, that surgery won't be
We'll all be
needed.
out
So
of jobs.
I know. So we'll see. Again, I think advances. It's a things are changing, and lots of good work going into breast cancer research. And so who knows? One day maybe.
Okay.
I don't
Well,
know.
I mean,
We'll see.
I actually I hope for all our.
Yeah.
I have daughters, and everybody has. We hope for their sake. But I'm going to ask now at the end of the show. I'd like to talk a little bit fun stuff. So first, I'll say, Dr. Williams,
Yes.
what do you like to do for fun?
Oh, so I've got two young kiddos.
Uh huh.
We're a biking family, and so that's
Okay.
one of the things. Moving to Lincoln, just like so impressed with the trail system here, the
Yeah.
biking. We did a family bike race in Colorado last year, a gravel bike race, and so yeah, my youngest finally just started riding her bike, and so
And
it's
if
been
there is
fun.
one thing the community doesn't know about you that could be cool, like I mean,
Oh man.
what would it be?
Um, Gosh, something. I love sports, so I'm a
Okay.
big sports
Fantastic.
fan. College sports. I went to UVA, so I'm always
Oh yeah.
loyal there. But moving to Nebraska, it's been fun to kind of get on that bandwagon. And I play basketball, which is fun. Not as much now. And love water skiing. So that's kind of
Okay,
my
water
summer
skiing. Okay,
activity. Yeah. So
love
there
it.
you go.
Okay, so water skiing and bikes. Okay, Dr. Latte, you
Um,
what do you like to do for
I
fun?
I'm a big crafter.
Okay.
I used to be my
Oh,
Yeah.
daughter's
okay.
Girl Scout troop leader, and we did a lot of crafts and things like that. And to this day, we still do crafting. I'm on the booster club for my daughter's high
Yeah.
school dance team, and so we kind of personalize a lot of different outfits for the parents for spirit wear and things like that.
Okay.
And then as a family kind of oriented thing, although not so much anymore because
Yeah.
my teenage kids pretty much don't want to hang out with me anymore. But
Typical. Typical.
we used to love to go to national parks. We've been to over 70
Oh,
national parks, and we do the junior ranger programs there so that you can just really learn and get the most
That's
information
awesome.
about those different sites and learn the history and about the people and the culture. So I still do that, plus minus my kids. Whenever I go to different places, I seek out a national park to attend and do the junior ranger program.
That's fantastic. Well, I'm going to kind of wrap it up, but what I'd like to make sure our audience knows is that AMI puts a significant effort to try to bring as much cutting edge medicine to this town. This idea of this whole podcast was to actually get to know our physicians, get to know our topics of what our physicians cover, because radiology has always been in the dark. We're going to bring it out to the light. I know it's not good for X-rays, but at least we'll try. I think it's going to be important to kind of know. I thought this was one of the most important topics, right? I mean, I think for everyone, breast cancer affects.
Mhm.
It's the most common.
One in
Mhm.
eight.
One,
Yep.
yeah. So
Yep.
I think it was very important to start with this topic because I think it relates to everyone, and I hope we can actually make an impact in healthcare like that.
Mhm.
Other than that, this was our first episode. I hope people don't boo us. And, I tried,
You succeeded.
all
It was
right.
good. It was good.
And I think that we'll call it a wrap. Thank you, everybody.
Yeah.
Thank you.